Thank you for the invitation to speak. Thank you for the very kind award. I feel a bit embarrassed by it and honestly feel like we should be doing much more than we have so far. So we'll try to do better next year. Sorry about that. I'm going to chat a little bit about assessing severity in SLC6A1 and other developmental and epileptic encephalopathies. For those in the room who don't know what DEEs are, which is what I'm going to say from now on because developmental and epileptic encephalopathies is clearly way too long. DEEs are kind of an umbrella group of epilepsies that also have developmental challenges, and that's sort of the larger group of medical conditions that we could think about SLC6A1 falling into, along with neurodevelopmental disorders is another term that often is heard, and so it kind of fits into both bins a little bit. And I will try to have less luck than everyone else with the PowerPoint. All right, so we're going to chat a little bit about the challenges around epilepsy as a primary outcome, and I'm thinking about this in the context of heading towards clinical trials, thinking about the patient perspective, related outcomes, and we'll give some examples of other novel outcome measures that we've developed for other conditions and that we've tried a little bit in SLC6A1, but it's pretty preliminary data. So, DEEs. Many of the DEEs that we are aware of have a genetic etiology. I would say the majority of them, though certainly not all of them. That underlying genetic etiology both leads to developmental challenges and to the epilepsy. And so disentangling the impact of the epilepsy on the development can be a bit of a challenge. And that's part of where pragmatically we talk about DEEs as conditions in which you have both of those, rather than being able to sort of say like how much is contributed to from what thing. So if your developmental challenges are there, is it really to the driver of the SLC6A1 or is the seizures doing it? And this is a great talk to follow the talks before this, both of those, because it kind of points to some of the individuals who had worse seizures also had a little bit more challenges on some of those developmental areas. So that suggests that there is a contribution potentially from both, that the SLC6A1 has its own contribution, but if you have a lot of seizures, then that may make it even harder to have development progress. However, we also know that it's not just the epilepsy because developmental concerns in SLC6A1 often precede the epilepsy onset, so we know that there's some aspects there already. And then we also know, as was beautifully laid out by Dr. Varnett, that the various, in epilepsy world, we call them comorbidities. Everything that's not epilepsy is a comorbidity. It's actually just, everything that's going on with patients. There's a lot going on that's not epilepsy related in SLC6A1. And so how does that play into everything else? Got to push it hard. Oh, okay, yep, okay. No, there we go. All right. So I may have actually. Oh, wow. You got to push it hard, and then you get like 4 jumps. Okay. This is going to be fun. Just a like arrow thing with the keyboard would maybe work well. All right, so CDKL5 deficiency disorder is another DEE that our group has, in Colorado, has worked a lot on. And so we've tried to take some lessons learned from that and some of the work we've done there and think about how would that apply to other DEEs like SLC6A1. When we're thinking about what should we measure for a clinical trial, it is really important that we think about what matters to patients and families. And so this is an example of one of the ways that we looked at that for CDKL5 deficiency disorder. We had something called a PFDD, a Patient and Family Drug Development, something along those lines. Anyway, apologize. It's FDA-run symposium that basically allows for the FDA to hear from families what matters to you. And you can identify then a list of challenges that may be important to patients and families when you think about what should we measure. CDKL5 also had a natural history study that was they participated in, and so you could also kind of look at, in that they had every family say, what are my 3 biggest concerns? And then they ranked what did they get the most hits on. Just as a little bit of context that I think will be important throughout this talk, CDKL5 deficiency disorder is a DEE where basically every patient has epilepsy. It is refractory, meaning like I throw as much meds at it as I can, and I very rarely stop those seizures. Like 5 to 10% of patients at any one moment in time might be not having seizures. So in many ways, the epilepsy is harder to treat than it is for many with SLC6A1. Some patients with SLC6A1 are in that spectrum, but many are not. And from a developmental standpoint, CDKL5, the vast majority of patients don't actually achieve independent walking or a single word. And so the developmental range is actually a little bit more severe than what we maybe see for the majority of our individuals with SLC6A1, fortunately. That's just as context to say, when we were thinking about how do we develop outcome measures and what are the things that are important to them, it may be different than what it is for SLC6A1. Interestingly, that's a disorder that has very little challenges around behavior. And in some cases, that may be because the development is so severe that actually they can't be as problematic from behavior. They can't run away, they can't yell, they can't hit. And as development improves in that group, we actually see more behavior problems. All right, so this is the stage that I think it is most important to have the patient voice in. When we're talking about what do we want to measure, we have to do a bunch of work to figure out how are we going to measure that well, how are we going to do it consistently, how do we know that we can trust the data that we're getting. But if we're not measuring the right thing in the first place, then what the heck are we doing, right? So we have to get that right from the beginning. I'm going to call out here that there is a disease concept model that is in process, that is being worked on, that hopefully will help to represent and be able to document clearly for the whole community and for any companies that are getting into this, what is important in SLC6A1 so that we can make sure that we're really anchored to that patient and family voice. Wait for it. I'm going to try to hit it again. All right. So this is just another way of thinking about what should we measure. So this is an example from Angelman syndrome, which has also been referenced a couple of times already, related to EEGs as a biomarker. And this is a similar idea where families were able to kind of rank what were the most important symptoms to have addressed in a clinical trial. Oh, man. All right. It's hard to know whether you're on the right slide, guys. I apologize. Okay, we are. All right. So a lot of times, and I'm harping on this a little bit because the knee-jerk reaction is actually to use seizures as a primary endpoint for most DEE studies. And I think that's highly problematic. And I'm sort of laying out a case for why I think that is. The reason we wanted to use seizures is because they're countable, right? So you can just kind of say like, oh, I know how to count them. We've had hundreds of successful seizure clinical trials. We know how to run those clinical trials. So that makes it very attractive to use that. The downside is the most common seizures for SLC6A1 in particular are not the easiest ones to count. So they tend to be short seizures, like absence seizures, which are pretty subtle. Was that a seizure? Did they just zone out for a second? They tend to be quick jerks, which also can be harder to count. And so we actually know from several studies that the reliability of counting those types of seizures is actually lower compared to other types of seizures, like generalized tonic-clonic seizures. You notice that when it happens, and it's pretty easy to count. So that's problematic for SLC6A1 specifically. And then I think the other part is that not all patients with SLC6A1 have epilepsy, and many of the patients who do have epilepsy may have uncontrolled seizures for a period of time, but that may come under control. Fortunately, in our experience, we've seen that most patients actually can get to control. They may have to try a few medications and things like that, and sometimes there's a bit of a question of, they're still doing some funny movements. Is that seizure, is that not? So working through that, but it's not all patients have seizures and we can't control them at all. And so that makes it a little bit difficult to say that if we're going to use seizures as a primary endpoint, that that's going to be representative of the entire SLC6A1 community. So there's a number of challenges when we think about the current outcome measures that are available for clinical trials. And I'll point out that several of those candidates, and maybe even good candidates, have been discussed. So developmental assessments, et cetera, that Dr. Barnett spoke to, and may be very appropriate to use for SLC6A1. But those aren't necessarily representing some of the symptomatic components. So how do we capture the symptoms that are happening in addition to the development and be able to track that over time in a reliable way? There's some other examples from again, other DEEs that kind of have looked at this and found that there are some shortcomings, even for some of those developmental assessments in some populations. All right. So while epilepsy, whoop, now we're just going. All right, so while epilepsy is a major concern, it's not the only concern. We're going to try to do this from memory. I have no idea what's happening now. All right. It does things when I don't push anything, just so you guys know. Like, I know you guys thought all those prior speakers were just crazy. It wasn't them. I could feel confident saying that now. And particularly when we're talking about disease-modifying therapies, and I'll draw a little distinction there. A disease-modifying therapy, like what Steve Gray works on, is something that is addressing the fundamental biology, so a gene replacement or an ASO. That should make all the symptoms better as much as possible, right? It's not just looking at one thing. A seizure drug is just designed to help make seizures better. A sleep medicine would make sleep better. And clinical trials can happen for those, and I think that should be part of the menu that Amber was talking about. We want to have treatments for all of these things, symptoms as well as the underpinning disease. So those symptom trials, it's great. Focus on that symptom. That makes a lot of sense. But if we're trying to do a disease-modifying trial, we need to focus on more than just one symptom or a couple of things. And we know that there can be major concerns around a whole variety of challenges. All right. I'm just going to mime this next year. It'll be easier. So how do we think about clinical severity from our group and the role that that plays in terms of what we would call clinical trial readiness, which is our ability to run a successful trial and identify that the drug works or doesn't work, depending on whether it does. I'm actually just filling time, guys. I'm pushing the button like constantly. So, okay. We might want to think about an alternative approach for the rest of the day. That's 2 slides later. All right, here we go. So we've had funding for the last 4 years from the NIH to develop clinical trial readiness and validate outcome measures for CDKL5 deficiency disorder. I kind of highlighted that. This is our network that's involved in that across the US and some of our folks in Australia, and I'm privileged to work with this team. This is a very busy slide with a lot of numbers on it, and the point here is to kind of summarize some of what we've done already for CDKL5 deficiency disorder so we can apply that for SLC6A1. So we have developed 2 different severity assessments, the clinician one and the caregiver one. Clinician on the left, caregiver on the right. You can see the domains that are assessed as part of each of those. So within the clinician one, we evaluate vision, we evaluate communication, we evaluate motor function. The caregiver one is a survey we ask families to fill out with a 1-month recall. So they're saying, like, how much have I seen these symptoms over the last month? And that has a domain for seizures, for behavior, for alertness, and for feeding. And then we can do a whole bunch of statistical analyses that as a group are called psychometric, which is looking at, can we get the same reliable result every time we do it? Does this structure of this assessment fit together and provide a cohesive evaluation? And so we've done all of that, and the short answer is that it met the requirements for what is standard for these types of measures, and we think we can reliably and accurately assess severity in CDKL5. All right. Back 4 slides? More? Okay. I'll try to go quickly on this part. So this is just an example of some of the items that are part of our severity assessment. So this is really things that are pretty standard, but it gives us a quantification of that ability. Next slide. All right, so clinician severity assessment scores. So this is overall. We've tested this within our multidisciplinary clinic for those families in the room that have actually come out. You may be aware, we don't just see SLC6A1, we see 3 other disorders in the clinic as well. The score for these is from 0 to 100. 100 is the worst end, 0 is on the best end of the score. And so SLC6A1 is in the blue, and you can see it's actually a little bit on those 2 sort of milder sides of the bucket. This was made for CDKL5, right? So we just took that and we started using it in SLC6A1. So this is actually what I would expect, is that we would be a little bit skewed towards the lower end of that scale, because many of the things we're measuring are more severe in CDKL5 than they are in actually all 4 of these disorders. But the question was, are we like even in the right ballpark? And so some of the items that we're dealing with here actually make sense. Some of them we probably need to modify or look at other things. Next slide. This is the caregiver one. We have a lot less caregiver data, and that is because it is hard to get you guys to fill out surveys for us, but we will continue to try, and we'll try to make it easier on you to do that, especially within our clinic, which is a whirlwind of a day. It's a very long day. There's a lot going on. So we want to get more data. I don't want to make too many comments about only 2 patients here. Next slide. This is looking at sort of the domains and how severe are they. So if the wedge is bigger, then that is more severe in that population. And the population of interest here is, again, yellow. And so I think there's a couple of things that jump out pretty quickly. And I'll just focus to the left side first, because the clinician we actually have more data on, and so I can trust this a little bit more. Vision wasn't a problem in any patients with SLC6A1 that we've seen so far. Many DEEs have something called cortical visual impairment, where the brain has a hard time processing vision. We didn't see that for any of our SLC6A1 patients so far. Doesn't mean it's not possible, but we haven't seen it. Motor and communication, we do see that there are challenges, maybe not as severe as some of the other groups or as what we saw in CDKL5, but we did see it. That doesn't mean it's not severe and it's not an issue. It means that our measure is not assessing all the things that are relevant for this population. So what this tells me is that my next job is to go and adapt these measures so that we actually can understand the challenges that face SLC6A1 families and patients a little bit better than what this measure actually captures. On the right side, again, this is only 2 patients for those yellow bars. There is a tiny yellow bar in the alertness domain of saying we're not as alert as we should be. Autonomic function was something that we saw as an issue. Seizures actually didn't show up at all. Again, just 2 patients, but we know it will for some patients. Behavior, off the chart. So I think that is capturing some of the challenges. We need more data for that one in particular to understand across a larger group of SLC6A1 patients. What's that look like? Next slide. And then this is just another way of plotting for SLC6A1, the 10 patients we have so far. Again, no vision and the range of difficulties in terms of motor and communication. And I'm going to keep it moving. And with that, I'm going to say thank you to my lab, our clinic folks, all of the people who fund our rare disease work, and particularly all of you in the SLC6A1 community. Thank you.